All right. Hey, everybody. Happy Monday. It is August 12th, 2024, and we are coming to you live right now on the Compliance Guy Monday Auditing, Coding, and Compliance Roundtable. We are a abbreviated team this week. Scott Kraft is making his way to Poland and the UK for what we're not quite certain of at this point. And Stephanie Howard is off on assignment. So I am joined by Christine, Paul, and our happy, smiley friend, Terry Fletcher. How is everybody?
Good.
Excellent.
Good. Well, I am excited to see everybody. How was your weekend, Paul?
Well, I went to Poland by way of a Polish wedding in Illinois this past weekend. I was stuffed to the rafters with food, and the younger attendees were stuffed to the rafters with dancing. So
there you go.
A splendid time was guaranteed for all.
Outstanding. And Terry, how was your weekend?
It was good. I don't think I needed to end it with the breakdancing with the Olympics. I really don't understand that. They took out softball and they've got breakdancing. See, there's my public message there. I'm like, what the heck? Yeah, no. I like the swimming. I like the gymnastics. I like stuff like that. But I don't think breakdancing should be in the Olympics. That's my positive message for today. How's that?
What was that? So I don't watch the Olympics. I haven't watched the Olympics.
It was a train wreck. I'm sorry. They had girls. They had the women's swim team diving into the Seine, which was, it had E. coli in it. People get mad at me if I say anymore, but I didn't like it. I was mad.
I'm just asking a serious question.
Breakdancing is in the Olympics. Believe it or not.
It's an actual Olympic sport.
We all lived through the 80s. That's when breakdancing was, and I don't see it being like that. And that was really cool back then.
In the 80s,
just this one time though. It was just a demonstration sport, and at the Los Angeles Olympics in 2028, it will not be there. Is my understanding? Yes, this is my understanding.
Okay, well, because in the 80s, I wore parachute pants and
I remember
the leather wristband with the the spikes on them and the mesh shirt, and I thought I was like from that movie Breaking, breakdance, whatever it was called.
Yeah.
And of course I couldn't dance. So anyways, before we digress any further, let's go ahead and jump straight in. And Christine, I do want to ask, how was your weekend?
Well, I didn't watch any of the Olympics, although the only thing I watch are the equestrian sports. I worked a little bit, and then we took the day off yesterday. Yeah.
All right. So I want to jump in with our very first topic, and I think this is one that has led to some indigestion. It has led to, I think, more questions than answers. And I think there's a lot of folks who are still kind of scratching their head after the Centers for Medicare and Medicaid Services did a public webinar, and they talked about the American Medical Association's position, and I'm guessing CMS adopting that position of prescription drug management in playing a role and what is required to substantiate a low, a moderate, or a high level of medical decision making. So I'll pause there, and Paul, Christine, Terry, whoever wants to kick this off, and we will go from there.
Well, I think that, we're looking for something cookie cutter to tell us what qualifies, what doesn't. And the truth of the matter is, what did it say? What did the provider do? What is the risk that they're trying to share with us? I don't think that they have to say this prescription drug management was of moderate risk. I think they just need to explain to us, what is the condition's responding well. Was there anything they told the patient about this medication? You might get nauseous. You might get sick. Did they talk about how it could interrupt other conditions, how it could affect other conditions? Did they talk about that? If they did, then that risk is present. Otherwise, I think we talked about this earlier. I mean, my dentist has a list. My massage therapist has a list of my medications. They're not treating me. How do I know when a provider says refill meds, what meds they're refilling? Are they prescribing those meds in that list? There's just too much there. I think we just need to go back to the old way of saying, here's the disease, here's the medication, it works, here's what I told the patient.
Well, and I'll take it a step further that I was reviewing a note this weekend, and the doctor was clear that I want to moderate on this. And I kept seeing a level 3. And it was a low level. It was basically coming in for a 6-month recheck. And there was a list, and I'm air quoting here, a list of medications. And it didn't even have if they were refilled or whatever. It had the start date. And so I said, yes, but where are you trying to tell me that this is, moderate? He says, look at the list of medications. I'm like, I see it. It's part of the history. He said, no. He goes, now I can have the, level 4 if I have the list of medications, because that's prescription drug management. I said, where's the management? I said, people don't know that, patient had Jardiance or they had metformin or whatever. We may know just because we watch commercials. I have a medical background, but that's not, I can't use that to infer in the record. Just like practicing nurses, practicing clinical, people, especially in a hospital setting, they can't say, well, because, I have this background, this is what the doctor meant. We're not allowed to do that. We have to make sure that if you want to get credit for something, you have to put down where the management is, where it ties into the risk of the management of the patient. See, that's the big thing. If let's just say the patient is diabetic and it's in there somewhere, and that the medication list is there, and diabetic patients have many of them, not straight across the board, but there's a known fact that they have a slower rate of healing potentially when they have surgery, whatever. Well, and also patients, let's say, are on blood thinners. There's an issue there with risk. But unless the doctor documents that risk, you can't make the assumptive jump that the risk is there, because now you are putting words into the doctor's mouth, and whether you're a clinician or not, that's not your patient. And it is the doctor's patient. It's the provider who's treating the patient, and it has to be their words on that risk. And, it reminds me of the thing that we also have in data points. And I love this, what Paul had said a couple of episodes ago, that when you're doing an independent interpretation, it's nice to have the actual picture there, or the trace, or the actual, not just a report. Because in the old rules, so 95 or 97, that's what it used to have in there. And even those have been retired. They haven't been deleted. We're still referring back to those a lot on there. But when we get back to the medical decision making, everyone wants the level 4 because the patient has a scripted med. And Paul, I'll throw it over to you on that, because I think there's probably something you have to add to that before we get back to Christine.
Well, actually, Christine had an interjection here to jump right over me, so I'll come in after Christine.
So, Terry, you know what? You're spot on, and I think people don't really stop and realize that the reason we have these codes is because one of the reasons is because somebody else is paying the bill. So, CMS, Humana, United Healthcare, whoever it is paying the bill. All they get is a claim form. The claim form says upper respiratory 99215. It would be logical for that payer to say, whoa, wait a minute. What makes this high level visit? Because all they see is the claim. So that diagnosis code, when we ask what would Jesus do, right? That diagnosis code doesn't support a high level visit. If you're a doctor worth your weight in salt, you give them a prescription for their upper respiratory, it resolves in 7 to 10 days, and they're back to normal. So 1 diagnosis code, 2 diagnosis code, 3 diagnosis code isn't really going to tell that story. And they're relying on the fact that if they ask for that documentation, or like we like to say, when they ask for that documentation is going to be real clear why this is a high level visit. And the last thing is, when they do get that documentation, guess who's going to review it? We are. We're not clinical people. We're going to be basing that on the guidance that has been given to us by the AMA or by CMS or by the payer themselves. So really, when we start having these conversations with providers, I'm not going to argue with them. I'm just going to remind them that your peers did not go to school for the same amount of time that you did so that they could sit and process claims, nor do we submit each individual documentation for the payer to review and decide what level that needs to be paid at. There's a system that's in place. That's all. Sorry.
So let me make a couple of comments and then let me ask some questions, right? Because like those who are following us, listening, watching, I always am of the mindset that if I have a question, a bunch of other people do as well. So my first comment is to the point that I always bring up during hearings in trial when the government marches a non-clinical auditor into the courtroom and they try to play, Trapper John MD or Quincy. And they talk about it. I had to throw those back to you, Paul, because I know those are your shows. But, when they start to talk about, well, this doesn't support a moderate level of medical decision making. This doesn't support a high level of medical decision making. And the first thing that I usually write down for the attorney who's going to do the cross-examination is, what clinical degree do they have to be able to speak to the level of clinical judgment that is made either by a PA, an NP, an MD, or a DO or a DPM? Okay. But beyond that, for me, I believe, and these are my comments, and I'm going to get to the questions in a moment, or to the question in a moment. For me, I believe what has to transpire is a furtherance of education and understanding for providers to make certain that in their documentation, because we no longer are required to meet the elements of the history and or examination, it has to be medically appropriate, right? And that's at the discretion of the provider. We have not seen, nor do I believe we're going to see, unless the AMA and CMS are concocting something that nobody's talking about right now, definitive guidelines for how to define a medically appropriate history or examination. That's to the discretion of the provider, and I think that's how it should be. But what I believe, as somebody who is tasked with having to defend providers in hearings and at trial, you got to give me information to be able to counter somebody on the other side who says this doesn't support high medical decision making. So I am not opposed to providers having to state that by Sean taking amlodipine and having a magnesium deficiency, this could further exacerbate that condition. So to counter that, we're also going to start 425 milligrams BID of magnesium. That paints a very clear picture. And I think that in my mind, as a regulatory professional, as a compliance person, as an auditor, that for me gives me the ammunition that I need to be able to go back to somebody and say, you're wrong, because the physician actually addressed, or the non-physician practitioner addressed why they were giving this over-the-counter medication, or why they were doing this combination, or why they were given this prescription. Now, my question that I have for Christine, Terry, or Paul, and you may or may not agree with my statement, and I'm curious as to your positions. Mine is, we need to do a better job educating the providers that they have to give us more into medical decision making when a patient has multiple chronic problems symptoms, or there's a potential that one of the problems they have can be, a contraindication to being put onto the medication. Now, here's the question that I have. And I think you brought up a very interesting scenario, Christine. If a patient is seen at an urgent care center, or they're seen by their primary care provider for an upper respiratory infection, and let's just keep this simple. It is somebody who does not have any other underlying uh, um, illnesses. There's no hypertension, there's no diabetes, there's nothing that they have to worry about. So the provider writes a prescription of a Z-Pak for the URI. There is nothing more that needs to be defined or described. So in that scenario, is it not easily inferred? Because remember, the guidelines do say something, as long as it's easily inferred, is acceptable. Would that not be easily inferred? The patient presented with the following symptoms. They were diagnosed with an upper respiratory infection, and as a result, we put them onto a Z-Pak. No further explanation. And I'm asking the question. It's not a loaded question. I am not a doctor. I don't play one on TV. I don't stay at Holiday Inn Expresses. So I am genuinely asking those of you who are frontline auditors. Terry, you audit for various payers. You audit for the government. What say you?
So for this one, this would be interesting for me because I also audit a lot of urgent cares. First of all, I'd want to see documentation that reflects not just that they prescribe the Z-Pak, but what their management of it is. So what do they expect if they take it for 5 days? And they should say, how long they want them to take it. If there needs to be follow-up on that, if there doesn't need to be follow-up on that, they should be fine. If they suspect that there could be another problem, like maybe an allergy, because upper respiratory doesn't just mean that they have a cold or have an upper respiratory, whatever. So it could be a couple of things. But I'd want more elaboration, more details from the provider with regard to that prescription. Not just, we're going to give them a Z-Pak, see you later. And I think a lot of times the providers, whether it be a physician or whether it be mid-levels who are taking care of the patient, they make this assumption that every single coder, auditor, biller, whatever is clinical. And I think that's a really poor assumption. But in saying that, then they get mad when you don't know. So they're like, we're assuming you're clinical, and they say, well, you should know that. And then when you try to counteract them or say, well, you didn't give me enough information, they're like, well, you should know that. So, or it's like, well, you can't tell me this. You can't have it both ways. It's either they know it or you're giving them information or you don't. And I think you have to have the physician state the management, state the risk. I know everybody always says things like it's not documented, it's not done. No, if it's not documented, it's not supported. It may have been done, but if I can't see it, if I don't read it, I can't make that leap. That's why we have something called a query. If you are making these assumptions as an auditor, a coder, or somebody that, and here's where you get into a trap. And these are for the listeners on here. And I know some of you are like, oh yeah, I do that. Once you start working for a provider, whether it be in a consultant perspective or as an employee, you get used to how your physician documents, how the provider documents, and you know what they meant to say. I mean, not to get political, but look what they're doing to a lot of the things that are being said by talking heads out there. They're like, well, actually, let's walk that back. Or actually what they meant to say, it's like, no, what you said was this, and that's not okay. And so in a medical record, take that a step further. What you didn't say or what you said is this, and this is as far as we can go based on the guidelines that we're trying to report. We are as good as what's in front of us.
Let me say something real quick, if I can, Terry.
Yeah, and then I want to hear Paul chime in on this because I know the audience as much as I do.
Yeah, you raised a really good point, and I always love when something comes up that I can take and tie back to a criminal defense case that I was involved with. A very big case. It was 4 defendants, almost $500 million that the government was demanding back, and there were 54 counts of an indictment against each of these 4 physicians. And you can look up the case. case, it's United States v. Bothra and Lewis et al. And it was in the Eastern District of Michigan. And as I was being cross-examined, the famous phrase that Terry just brought up a moment ago, which is, if it's not documented, Mr. Weiss, it wasn't done. And my response was, well, just because something's not documented doesn't mean it didn't happen. And you should have seen the jury reaction, and you should have seen the prosecutor's reaction. Because the fact is, providers, the majority of them, are atrocious when it comes to documentation. And there's a lot of reasons for it. And it doesn't make it right, but they're not great documenters. But I love what Terry said. If something's not documented, it probably is not going to be supported. So that's, I think, there are ways to be able to communicate points to a clinician. No doctor wants to hear you say, if it's not documented, it didn't happen. The doctor's going to say, bull crap. The patient signed in. I've got a note. Okay, fine. I didn't say it, but it doesn't mean I didn't do it. I love the statement of, if you don't document it, there's a high probability what you bill for won't be supported. I love that. Paul, go ahead.
Well, I hate to be the person who flogs a dead horse in defense of physicians, but currently I look at the calendar and we are in the 44th month after we have changed the E&M guidelines back in 2021, and we tend to use the phrase "moving the goalposts" when we tell the physicians to document a certain way or to capture certain pieces of medical information. But we are still dealing with physicians who have not updated their documentation templates. So if you're moving the goalposts on a baseball field, what's the difference? It is far past the time, and I've made this point multiple times on this podcast, where documentation templates that are currently engineered for documentation standards that were designed in 1995, in my case, at least one marriage ago, need to be updated, and they need to reflect current state of documentation standards, and we can educate the providers, but it has to go hand in hand with a redesign of what type of documentation they are putting forward, and the type of documentation based on the templates that are stale dated and still out there. We're going to keep running up against this until we get a change in those templates.
Go ahead, Christine.
Oh, I just wanted to jump in. Terry, you are spot on when you talk about the information not being where it's supposed to. My biggest problem is that now that and I hate to keep going back to the electronic medical records, but I just want to remind providers again, that's your tool. That's it. That's not your go all be all. And just because there's not a button there to click, it doesn't absolve you from still reporting what's in the best interest of the patient. Like you were saying, Terry, what if they had a closing statement that said, patient should return to the office if the prescription drug medicine does not become effective within 48 hours. I mean, that to me shows that there's some skin in the game, but there's no button for that. And the other thing is that you're 100% right. Now that these EMRs have got so many different sections and things go in different places, when I'm auditing, my go-to statement is based on the documentation available for review, because it could be in one of those other 30 tabs that are in the EMR, but the provider still needs to be responsible for telling me that they have the results of the biopsy, or they reviewed the x-rays in the x-ray section, or where did you get this information, just so that I can follow you down the rabbit hole of this electronic medical record kind of nightmare there. So that's what I wanted to kind of pipe in on.
And I think, to Betty Hovey's point, I agree with her. The EMRs, many of them have not updated their templates, so they're complicit in their responsibilities.
Right. Well, the
Um,
other thing too,
go
and
ahead,
Sean and
Terry,
I talked
please.
about this before on our hashtag Terry Tuesday thing. One thing I've noticed with payers is they're getting a lot of level fours. They used to be all about look at all these level fives, and they're getting a ton of level fours because it's so much easier to meet in the now than it was before 2021. But the one thing I look for, and Christine mentioned it, is when a doctor says something like patient needs to follow up in a week or patient needs to follow up in 10 days. So I go and look for that follow-up visit. What do you know? Big percentage patient never came back. Nobody ever followed up with it. There was never a reach out to the patient. Why didn't you come back? So to me, that negates their risk. I'm like, where's your risk on that visit? You're trying to get level fours. You said the patient needs to come back, but if they don't, that's okay too. That means you've now said PRN in effect because nobody followed up to see if
Yeah.
the patient was okay.
Yeah.
I mean, let's not even get into malpractice potential
Well,
there,
yeah,
but
and,
they've
and that's
got
a
to
big,
be
yeah,
they've
that's a
got to
big
be
We've
problem.
really
gotten so
careful.
far away from malpractice
Yeah.
that
Yeah.
it's ridiculous. If you read these notes, and I'm just saying from my own personal experience, I'm stuck in audit world all week long. And
Me
when
too.
you read these notes that are copy pasted, that are templated, I'm afraid for the patients sometimes with what I see in the medical record. I did an education last week to a provider group, and I showed an example where they copy pasted a fracture. It was one of the fractures that was compromising the blood vessel, and it was of an urgent measure. And they were reporting this active fracture at every visit for an entire year. Never did it get resolved. It was just a copy paste issue. I could only imagine that an attorney would have a field day. You let this person go a year and a half with a fracture that they could have lost their foot, and you did nothing for it.
Well, I'm starting to look at telehealth visits for payers. Now they're saying, okay, so you've had it for about 4 years. Let's go back and take a look. And they're looking at
Right.
2020, 2021.
Yep.
And basically, I've seen things that say the patient has a potential mass that they felt, and we don't know what it is, but we'll just keep an eye on it. From a telehealth perspective, then fast forward 6 months, patient's got Hodgkin's lymphoma. I'm just like, you missed it because you felt that that could be done virtually versus bringing them in. If there's anything that says that they have a palpable anything, bring them in, and it concerns me because so much of this is actually in the documentation that you're trying to get paid this
Yeah.
higher level for. And I always know that I have a practice that I need to really watch out for and start with compliance versus coding. When they say to me, our doctors want to be trained on how to get to a level 5. Oh my gosh, just face plant me.
Yeah.
Yeah, I'm just like,
Um,
that's not what we do.
y-
We
you
don't
know,
do that.
you raise a really interesting point about telehealth services. Um, you know, I think a lot of folks that are listening today understand the statistics, right? Prior to the public health emergency, they were being used, I think, less than 5% of patient visits. The public health emergency hit, through the various waves, 83% or greater of all Medicare beneficiaries were receiving telehealth services. These are a huge audit target. And I have some of my clients because I have the privilege and honor of serving as a chief compliance officer for a number of uh, medical practices and health systems around the country. And there are still many providers that think it's okay to sit on their couch in between watching different Netflix programs and do a telehealth visit. This is not what telehealth has been created for. Telehealth was created, obviously, number one, to ensure everyone and anyone during the public health emergency who needed access to a medical provider could get it. But the reason for telehealth being carried forward and the reason why it was put in place in the beginning was to ensure that those in rural areas or medically underserved areas, including the inner cities where there's a lack of access to providers, could receive at least initial medical attention to triage and evaluate a situation, and then to make a determination as to whether or not the patient needed to be seen. I, unfortunately, in working on the number of litigations that I am brought into, the amount of fraud, telefraud that has transpired during the public health emergency and still after is absolutely mind-boggling to me. And this is why I think the Department of Justice, the Office of Inspector General, the Unified Program Integrity Contractors, the Special Investigative Units are being hyperactive in their audit activity of these services. And I think they also recognize the fact that there has been so much, complicity on the part of the EMR vendors in failing to update their templates from 95 and 97 to better allow and, dare I say, require providers to use the free text portion of the documentation within the EMR. And I can see at some point a provider who is charged with healthcare fraud or abuse or, criminally charged or charged under the False Claims Act for civil, going after an EMR company.
But Sean, did you see what the Medicare update said? Christine and I have been reading on it, and
Yeah.
we're like, you've got to be kidding me. So there's 17 new codes coming out for telehealth through AMA CPT.
It's
And we
crazy.
were like, yay, no, we were happy about it because now the E&M that has an included physical exam is not going to be an issue because we're hoping that the new telehealth visits are going to actually reflect what telehealth is, right? Well, then the proposed final rule under the Medicare Part B fee schedule said, we don't think we're going to use those. We're going to make them under, status I, meaning needing more information and we might extend just another year under the regular stuff, basically because we're lazy butts and we don't want to figure it out. I'm sorry, but I'm so mad about this. And I think it's on page, Christine, 256 or somewhere way, way into it. And we're reading it and I'm just like, you've got to be kidding me. This was a way out, a way to finally get compliance on telehealth. And it's awful. And I'm
Carrie,
just,
they also didn't say that they were going to continue with any of the waivers for site of service.
Right. Place of service. Right.
As it stands right now, without some sort of act of Congress coming in, if this proposal goes through the way that it has been given to us, we're going to go back to originating sites. Telehealth is going to become a huge, huge disadvantage all the way around.
Right. Well, and because they are deleting the audio only, if they don't let us to use some of the new codes, audio only is done as of January 1st. So, which I don't actually hate that because of Pam's, her thing about the phone call. I'm really happy about that.
Yeah.
But we've seen in the previous proposals and in the previous final rules over the last couple of years where they've said, we're going to continue what was put in place during the PHE. That wasn't in this proposal.
No, it wasn't. Yeah, they've said that that won't happen. Yeah, which I think, telehealth, and just so everyone knows, I think we are all proponents of telehealth when it's medically necessary, when it's indicated, people who just need that, that check, that they don't need to come in, or I think it's great for like pink eye and things, contagious things where, that the one that Sean said, you need that Z-Pack because, you're coughing your guts out and you don't want to give it to everybody else to come in the office, things like that maybe. Yeah. But, when there's things that are neurological defects, when they are palpable masses, when they're chest pain, telehealth is probably not your answer. And I'm saying probably because I don't want to be, saying I'm a physician here, but common sense tells me there are certain, presenting issues that you have to rethink it. But we've gone so far down the rabbit hole with doctors getting used to getting paid certain things that they don't want to pull back. Yeah. As Pam Vanderbilt said, thank you, Pam, for that comment. She has providers, she's having to still tell them, 4 years later, after the PHE and 1.5 years later, after it's already been ended, that you cannot call or you cannot give patients or you can't bill for a telehealth visit for normal test results. We didn't do it before the pandemic. Don't do it now. That's part of your triage.
In having this whole conversation about COVID and the public health emergency, it reminds me of, at one point where, everybody was having to, like visit grandma who's in a nursing home and you could only
Ugh.
talk to each other
We
through
had
a
to talk to
window
my
and stuff.
father-in-law through the window
But
when he was in the skilled nursing facility.
this past week, last week, so when I came home from the hospital, my my two grandbabies who live directly next door to Jill and I, they both got COVID, and it was so heartbreaking because when I came home from the hospital, they couldn't come out and see me because they were both standing in the window and they were waving. And it was like, oh, and it brought back all those brutal memories of having to talk to people through a window and stuff like that. But, I agree. I think the use of telehealth is where, you are trying to protect people like myself who are highly susceptible to infections and things of that nature, because of like me, I have advanced heart disease. So for me, I have to be extremely careful and cautious. So I think in certain places like that, like me
Yeah,
not
it's
wanting to
the
go into an office, I think telehealth for somebody like myself, where my immune system is compromised and I take 11 medications a day. I don't want to have to deal with something if I don't have to.
right. Or
But
like what Barbara Kabuzzi says there for monitoring conditions like well-controlled diabetes.
100%.
Yeah, but Sean, here's what I'm getting on the
Yeah.
feedback when I say, you can't charge for that normal test result or those lab results. They say, okay, so should we just tell the patient, no news is good news if we don't call you so that we don't have to use that? I'm just like, oh my gosh, no. You have to have a follow-up in place for not only test results that need further treatment and workup, but also normal test results. This is a compliance issue.
It is 100%. This is a
Not.
compliance issue, but I
It's
think,
not a charge one, but
yeah,
it's a compliance issue.
I think to tie this one off in a nice bow, I think all of us are on the same page that it comes down to providing more education to the providers, making certain that they do not rely on documentation templates within their EMR that have not been updated from 95 and 97 guidelines, helping them, not browbeating them, not kicking them in the teeth and telling them that you're screwing up and doing everything wrong, but helping them to understand that, listen, the 2021 guidelines changed the way you document. And the way you document now is the way you documented when you were in medical school. You have the SOAP format, the subjective, the objective, the assessment, and the plan. And to use Pam Vanderbilt's, words, and I'm probably going to screw it up, they need to think in ink. They need to get back to giving more explanations, more detail, more information to help non-clinical individuals who are tasked with the responsibility of making a determination as to whether or not a level of service is supported based on the documentation that's provided to them. It all comes down to education. Go ahead. One last word on this, Christine, and we'll
I
move
was
on.
just going to say, let's stop thinking about documentation simply for a financial perspective. I mean, we do need to have that documentation to back up what it is that we're billing. But let's remember that the medical record is also for legal purposes. If you had to read that record in court, blow it up on a big screen so everybody could see that record, can you stand by it? Right? Can you honestly say that information in that record supports the good treatment, the quality of treatment that you provided to that patient? I mean, I know we're talking about compliance, but we need to also remember this is a record that's used for continuity of care. You're going to share this with your colleagues. You're going to share it in court, and it's to support your payment. Otherwise, it's not just to get a 99215, guys.
That's right. And remember the legal portion of the medical record, and you hit the nail on the head, Christine. It is to ensure that anyone who assumes the care of the patient can do so in a safe and prudent manner. There should be no guesswork. There should be no questions as to what has been the care up until the point where another provider had to engage. So I think this was a brilliant discussion. It went way longer than what I thought it was going to, but I think it was outstanding. And I hope everybody who's watching and listening would agree with that. So let's move on to the next topic. And Paul, I said at first we were going to do yours, but I want to go to Christine first, and I want to talk about this because I want to save yours for last because it's kind of a tongue in cheek in a way, if you will. So I want to hit Christine's if we can. Go ahead, Christine.
So I've been working on a lot of really interesting projects, and I had a DME project, which I think now at this point, every time I hear DME, I know it's going to be interesting because sometimes it's not always being the advice that's being given by the DME company. Sometimes that is not always in line with what we should be reporting. I had a provider who was billing for a dental apparatus, and I had to ask, did you not feel that it was kind of weird that you were billing for surgical procedures when you were just placing this device in someone's mouth to see if it fits okay? I mean, your documentation is a sentence long, apparatus fits as expected, and you're billing 2 surgical codes from the musculoskeletal section that's reimbursing you about $1,600 in addition to the device for popping it in and popping it out. Once we looked at the CPT assistant, we looked at all that information, but this was millions of dollars that we were looking at that this provider was getting paid. And it takes me to another one. I have another audit that I'm working on where the provider says the DME supply company or the medical society told me to code it this way. And so I don't know why I'm getting a massive overpayment right now when they told me to bill it that way. I said, well, if you look in CPT, that's not the description. CPT assistant gives you an example, and there's a payer policy that tells you what's the indications and medical necessity. So I don't know the guidance that you got, but here's the facts.
Yeah. So we actually, and Paul will talk about this as well. Within DM, for all of our clients that we do the regulatory compliance services for, we have a program that I created called the vendor validation. And what happens is prior to any of our, and let me tell you, it takes a little while to train our clients, but every single one, Paul, I think you would agree, every single one of our clients, and the numbers are staggering, who reach out to us, they do not engage in bringing any new supplies in-house, whether it's amniotics, whether it's wound coverings, whether it's boots, or whatever it is, without first sending us all of the literature from the distributor. We get the HCPCS codes that they are recommending, and we get any other coding guidance and or advice that they are providing. And then our team, Paul, Scott, Stephanie Allard, myself, go through all of the CMS national coverage guidelines. Then we go directly to the MAC guidelines to see if there's anything in alignment with that or anything contradicting what CMS as a national has put out. And then we go look for any other authoritative supporting information. I cannot tell you how many times we have seen just pure garbage being provided by these distributors. And Paul, I want you to talk about how many providers we saved during the amniotic fluid debacle of Fluid Flow and some of these other ones that were out there, where they were coming to us and they were saying, but they have a Q code, Sean. Look, we're getting paid $2,500 per unit. Go ahead, Paul.
Which leads me to the overarching point here. Just because there's a code for it doesn't mean that you automatically get reimbursed. That is not a lottery ticket. That is a code that has been built either by CMS under the HCPCS system or CMS. And I can extend this into the category 3 world, because there's a lot of optimism every time the category 3 codes come out every year that, oh, now I can bill for this. Well, isn't that wonderful? There's no reimbursement behind it, but go right ahead. There's also no FDA approval for your amnio substitute, that their amnio product that you're trying to inject for a musculoskeletal condition, which we are literally 10 years down the road before we get an LCD that really points out whether these things are covered for musculoskeletal conditions. You understand that, and I don't blame them for this, because it is in their job description. Every vendor and every drug rep that comes into your practice is trying to make a sale. And good for you. Everybody needs to make a living. Everybody needs to put food on their table. I'm not begrudging you that, but to also make a sale and make financial promises to the provider that you can bill under this particular code, and we have the Medicare payments to prove it, while you have the initial Medicare payments to prove it. What you haven't shown me is the clawbacks that follow those initial payments that make things very, very painful for providers. And we're still seeing bad advice about fluid flow products. And this is 4 years after we initially started seeing this.
That's right. That's right. Listen, we are not questioning the efficacy of these biologics, these injectables, the efficacy of these supplies. What we are saying is, do your own independent research, because the role of a salesperson is to sell you something. And they are not coding experts. They are not compliance experts. They are salespeople who are given literature. They are given information from their organizations, and they are told to get it into as many provider practices of this specialty as possible, because that's how companies make money when they make investments into research and development. Before, and the other thing, for those of you that are auditors, compliance professionals, practice managers, administrators of your organizations, when a doctor comes to you and says, hey, Dr. Spencer down the road is doing X, Y, and Z, and he's making a killing, why aren't we doing that? The simple response is, get me all the information that you can from Dr. Spencer's office. Let me take a look at it. Let me vet it independently, or contact individuals who can help me independently and objectively vet it. And then we will go from there. And if it's something that makes sense for our organization, if there's clear guidance, or at least enough guidance that we can direct you how to document correctly, how to code correctly, then absolutely, we're all for it. Nobody's here trying to prevent anyone from making a dollar, but you got to be smart about this stuff. And again, I am seeing some incredulous, not incredible, incredulous contracts coming across my desk from my clients, from some of these vendors, where they are one-way indemnifications, because they know if you don't see a bilateral, not bilateral, a two-way indemnification where both parties are held harmless, and it's only one-sided, there's a reason for that. And that's when my BS antennas go up. All right.
You know what else,
go ahead,
though, Sean? How do you know Dr. Spencer's not on a corporate integrity agreement? How do you know
Very
Dr.
good
Spencer
point.
hasn't had to pay back money? Like I keep saying, if I got pulled over and got a ticket, I'm not going to go shout it from the ceiling, hey, I got in trouble today. I got to pay a lot of money.
Yeah.
Dr. Spencer's not doing that. Other providers are not doing that. So, I often have to laugh a little bit when they say, well, everybody else is doing it. But do you know if anybody else is also paying back their money from doing that? Or are they in trouble for anything else that's going on? You don't know. You don't take the time to investigate that.
Yeah.
Sean, I have a question for the panel.
Yeah.
So one of the things with DME that I deal with is I have a lot of, or a few, I should say, not a lot, podiatrists, and they deal with diabetic shoes. Well, to be able to get those paid, you have to get a referral first from the primary care doctor that says that the patient is a certain type of diabetic and that they need them, that there's some issues there. And also not just the referral, but also a copy of the last note that they had that reflects that. And that note also has to reflect that they did want them referred to a podiatrist to be fitted and to have them ordered. And then once they are at the podiatrist office, then they have to use that information to be able to bill for it. And if it's requested, which it seems like it always is, that has to be available to send. And I find that a lot of, it seems like one out of every two podiatrists said, well, my staff said I really don't need to do that much anymore. If I think that they need it, then I don't really need to get the referral. I said, have you read the guidelines? And it seems like nobody is reading the guidelines until, I think you call it, what is it, pay and chase. And then all of a sudden they have to come back and send the money back. But the other thing that I've noticed, and I don't understand this at all, and this is my question to the panel, I've noticed that DME seems to be the lowest hanging fruit for the OIG. They are just like, let's really find where all this nonsense is. And then I noticed that as soon as I see several reports on DME, CMS rolls back some of the rules on it. And I'm just like, what are you doing? Are they baiting providers and basically saying, let's see if we can even get you further? So I don't understand some of that. But I guess my point of this is, first of all, if you are a staff member, and I saw this post over the weekend on LinkedIn, that comes to a practice and you say that you have experience in what you're doing, that you understand the rules in what you're doing, if you are a coder, biller, compliance person, and that though that's part of your resume, whether it be on paper or what you talk about, that you understand this, please don't fabricate that information and not understand it, because your provider, your physician, they're relying on you that you do know what you're doing. And I think it's becoming a problem that I'm seeing, not just in that specialty, but even in cardiology, which is my number one specialty. I see people all the time saying, oh yeah, I can do cardiology, and then they can't. And I just, or even interventional radiology, which talk about being dangerous and not knowing that. But it really concerns me when I see people, especially billing companies, that say, we'll handle this for you. And they don't know the difference between contracting and credentialing, or they don't know the difference between, what a prior authorization is versus, having backup if it's requested. And just in the DME realm, I just noticed that this is becoming a problem.
Terry, you and I actually did a great hashtag Terry Tuesday episode not long ago about the difference between contracting and credentialing.
Yeah, you did.
So, and then I did a whole blog piece about it as well. So if you want to listen to that, you can go and find it. Okay. In the last,
Terry, I was going to answer
go
Terry's
ahead.
question real quick.
Yeah. Go ahead, please.
Terry, when I'm teaching, and I do a lot of education on people that are coming into this industry, I teach them one thing. Don't ever say Christine told you, because Christine's never going to tell you. I'm going to show you. I'm going to give you a link. I'm going to give you an authoritative resource. So when you say that you know something, it's not because Terry told me or Sean told me or Paul told me. It's because here's the authoritative resource from the payer themselves or from the Federal Registry itself. And that's what we've got to start reminding people. You're an expert because you have an understanding of the facts, not because you got paid and got away with it. Big difference.
Absolutely. All right. So the last thing that I want to share with everybody is Paul Spencer's topic. And we're not going to, there's no need for a huge debate. I just want you, Paul, to introduce to everybody what transpired with one of our favorite payers.
Well, yeah. And the subject you've chosen is United Healthcare. Yeah.
Thank you.
So we have, Health Partners, who is a large medical operation in the state of Minnesota that runs hospitals as well as clinics, has decided that they are terminating all their contracts with United Healthcare for Medicare Advantage, which is quite extraordinary for this particular group, because they're dealing with about 30,000 insured lives that they usually see at their facilities, who now either have to get a new Medicare Advantage plan or they have to find another facility in their area. 2 points I wanted to make about this. The biggest reason why they wanted to drop UHC as an insurer is because compared to other Medicare Advantage plans in the same area, for the same facilities and clinics, they were dealing with a denial rate that was 10 times higher than their other major insurers, which, depending on where these hospitals and clinics are located, has an extraordinary effect on the bottom line. And I'd like to tie this in with another story that has been flying around in some other news sources that have brought this to the point. There was a study that was put out recently that there are roughly 700 rural hospitals who are on the verge of closing. And a lot of that is because of their insurance payment rates and insurance denial rates. And when you're talking about a rural hospital, you are talking about facilities that are on a knife edge with regard to costs and with regard to just keeping their doors open financially. And we have several rural hospitals that have just basically decided we're not going to take Medicare Advantage in our facility, or we're not going to contract with this particular payer because the cost of doing business with them, as far as their denial rates and as far as their ever shrinking reimbursement rates, is just not worth it. So hooray for health partners, as Barbara Kabutsi said in our comments here. But I don't know if this is going to be a trend, but I see it as a step in the right direction for health facilities who just have said enough. We're not going to take this anymore. Find another payer or seek care elsewhere.
Excellent. All right. And that is going to take us right up to the end of our Monday Auditing, Coding, and Compliance Roundtable here on the Compliance Guy program. I want to thank Christine Hall, Paul Spencer, Terry Fletcher for spending some time with us today and putting on a great discussion. I want to say thank you to each and every single one of you who continuously logs on, joins in, and hangs out with us each and every single week on the hashtag Terry Tuesday episodes and every other week for the roundtables. We greatly appreciate y'all. Thank you so much. We will be back next week with a brand new hashtag Terry Tuesday episode, and we'll be back in 2 weeks with a brand new roundtable. So until then, remember, be good to yourself, but more importantly, y'all be good to each other.